Welcome, my friends, to the Bob and Brad podcast, produced by Bob and Brad, the two most famous physical therapists on the internet. I am Bob, and my guest today is Dr. Dane Hansen. He's of Summit Orthopedics. He's a orthopedic surgeon, and he does knee and hip replacements, and we'll get into it. Welcome to the show, Dr. Hansen. All right, Dr. Hansen, thank you so much for joining us today.
You're welcome. Thank you for having me. It's a pleasure.
Well, as we were talking about, we got a lot of questions, and I hope we can just dive into it.
That sounds perfect.
Okay.
Go ahead.
Why don't we start with your backstory? Maybe give us a little background of yourself.
Yeah. Yep. So I was born in the Twin Cities in Minnesota. Have been here most of my life, other than some of my medical training. So grew up here, went to Bethel University in the Twin Cities, played baseball there, and then ended up going to medical school in Des Moines, Iowa, and have moved around a bit since. So I did my residency training in orthopedics in Columbus, Ohio, and then my fellowship and my specialty training was a year in total joint replacement at Rush in Chicago.
I see.
So that was kind of my last bit of training, and ever since I've been back here in the Twin Cities. I'm one of the joint replacement specialists at Summit Orthopedics in the Twin Cities here in Minnesota.
Yeah, let me take this occasion to mention that the website is summitortho.com. It'll be in the description below. I also want to say, when I looked at the website, I saw 55 testimonials under your picture, and they were all very positive. You're obviously a good surgeon and a good person, so they really like you.
Well, thank you. I appreciate that.
So we're going to talk about hip replacements first. What are the indicators it may be time to have a hip replacement?
Yeah, a good question. Hip arthritis, really arthritis in different joints kind of show up different ways and with different symptoms. But hips, the main two things obviously are pain, and then typically range of motion restriction. So stiffness in the hip, difficulty bending, twisting, those sort of things. And, everyone tolerates a different amount of that. So, when is it time to have surgery is a pretty fluid question, but it really relates to, how bad is your pain, how long has it been going on, and how much is it, affecting you. Number two, how well can we control it, with medications or injections or things like that. And then kind of the big buzzword you hear a lot in joint replacement or in arthritis is quality of life. And again, that's subjective, but it's really based on, is your lifestyle and is your function what you want it to be to have that quality of life, whether you're still working, whether you're retired, whether you're just trying to be active, whatever it is you're looking for. And so that's a big part of the job, is figuring out when people hit that point, and when we've run out of other options to try.
Yeah, it seems to me that a lot of people, when it starts affecting their sleep, is a bad one, and also if they're on opioids, that want to get them off.
You got it.
Right.
Yep, exactly.
So this actually may affect that somewhat. This next question: how long can the average person expect this whole hip replacement to last nowadays?
Yeah, that has gotten better and better. So the current style we're using, or the current kind of technology we have, has actually been in use for about 20 years, and we do not yet see any real signs of wear and tear. The prior generation, 15 to 20 years, was about as good as it got. You'd see some significant wear and tear on the bearing surfaces, but so far so good with the new materials. And so we expect anywhere between 25, 30. We really don't know. I think 30 years is kind of what I tend to tell my patients.
Wow.
Is our average expectancy.
That really changes things. I mean,
It sure does. Yeah, it makes it a lot easier to
make the
make that decision when you're
right.
not worried about how, having it done 2, 3, 4 times,
Right.
if you're younger.
Exactly. So how do you decide if a patient is a good candidate for partial hip replacement?
Yeah, so partial hip replacement is kind of an interesting one. It sounds like if you look at it, it would be something that might be less invasive or an easier way to fix problems. But really, partial hip replacement is almost solely used for fractures. So elderly patients that fall and break their hips, if they don't otherwise have arthritis, you don't need a full hip replacement in that scenario. You can just replace that broken ball of the hip joint. And that would be what you would call a partial hip replacement. So anyone with any significant arthritis that's going through a replacement surgery for that, the arthritis is almost, globally on both sides of the joint, in the ball portion of the joint and the socket. And so a total hip replacement is really the only option to fully solve that problem.
I see. Well, I'm going to go off script here a little bit. If someone has significant osteoporosis, how does it affect your decision to, move forward?
Yeah, it plays into it. I would say osteoporosis in and of itself is not a full reason to say you cannot have replacement surgery. What we do is, as you look at the types of implants and the way that we fix those implants into your bone, the majority of patients have what's called a press fit hip replacement. So it doesn't use a glue or a cement or anything to hold it. Your bone structure is strong enough where those pieces just meet and they stay solid, and actually get some bone healing that can happen to those implants. In that, with the theory that would be a longer lasting situation. Right. But in a more elderly patient with osteoporosis, you can use, we use the term cement, but essentially it's kind of a glue or a grout that hardens very quickly. And so you can use that to stabilize the implant in the bone, in patients with weaker bone or concern that, a tight fitting piece might cause a fracture or something like that.
I see. So with a press fit, are they non-weight bearing or partial weight bearing after
full?
They are
full weight bearing, yeah.
Wow.
And so same thing, the technology has progressed, and probably just the process of rehab has progressed. We used to, if you looked at hip replacement 20, 25 years ago, most people were partial weight bearing until those implants could fully ingrow. We trust them more now, I think, technology wise, and we've just seen it long enough and understand it well enough to know that immediate weight bearing really doesn't increase the risk of having, a complication afterwards.
So this next one is a big question. If someone decides they're going to have a hip replacement, so there's 3 different surgical approaches, as I understand. You have the direct anterior front approach, side approach, back approach. So how do you decide which one?
Yeah, that's a pretty debated question right now. So
that's what I thought.
I would say on average, probably the main decision point for that for most surgeons is the comfort of the surgeon. Sure. So, training background, just, experience with one versus the other. Depending on where you train and when you trained, you probably learned one approach more so than others. So that plays a little bit of a role into it. Sure. Surgeons that do more than one approach do use some factors, age, body size, things like that, because certain things make one or the other easier or harder. Personally, I perform the posterior approach.
Sure.
If you look at the posterior approach or any of these approaches from, the past to now, the invasiveness of them has drastically decreased. There's much less invasive, even if it's considered more of a traditional approach. It's done very differently today than it was years ago.
I see.
And so what when we make those decisions, again, I think, for myself personally, that's more of a comfort thing. That was my main training. That's where I felt most comfortable as I was learning how to do these myself. But then second of all, I do a lot of revision type procedures, which are the, replacement of a replacement, or a patient that has damage or a fracture or an infection or things like that. And that posterior approach can be taken from that very small, minimally invasive approach to a much more extensive approach to solve any major problem. And so to me, that just, kind of makes the most sense for what I do.
No, I don't know if this is correct, but when recently the anterior approach, it seemed like the buzzword, the buzz belief was that there was less dislocations and it was you can be more active with it. I mean, but that's really not turned out to be true, right?
Yeah, I think that was the initial idea behind it. Again, as you look at the posterior approach, if you are going to have your hip dislocate or pop out of place, the vast majority of the time that's going to go out the backside of your hip. And so, kind of the theory was, if we kind of go through that backside of the hip to do the surgery, now you're at higher risk of that tissue failing or having an issue. And so for many years, posterior approach had what are called hip precautions. And so that's, restrictions on how far you bent, how far you twisted, if you could cross your legs or not, all these stipulations for, sometimes some surgeons would do that for even up to 3 months. And so that, as you can imagine, would slow down the recovery process. But same idea I guess what I should say is that, so the anterior approach came about with the mindset of, we're not violating that tissue.
Right.
And so in theory, this is a much more stable situation. And so those restrictions weren't put in place, and patients were able to get up quicker, move more, quickly through the rehab process. But over the last 5 or so years, I would say the posterior approach rehab protocol has caught up. And so we realized again that a lot of the basis of why we were doing those precautions was based on the more extensive approaches, more soft tissue damage, and those dislocation rates were higher back in those times. But we've really shrunk that down and gotten to a point where, most of us that even do posterior approach don't have any formal restrictions.
Really?
So the rehab protocol is essentially no different any longer. And so that's where those differences in, that faster recovery that maybe we're seeing early on with the anterior approach have kind of disappeared now that we've allowed everybody to rehab the same way.
Yeah, it's funny. Well, I'm old enough to talk this way. I mean, years ago at the Mayo Clinic, we had 15 doctors, and they had 15 different protocols for the patients. I mean, it was just insane. So, all right, that's very helpful. So, so we're talking about, do you see some common mistakes that your patients make after a hip replacement?
Yeah, I do. I think, there's kind of hip replacement, if you compare it to knee replacement or shoulder replacement, is actually a little bit simpler and more straightforward of a recovery. For whatever reason, hip joints really respond well to replacement. I think it may be something to do with the mechanics of the joint, or how the implants, function so well immediately. But even with that, there are, I guess with that, I would say that I do see patients tend to potentially move quicker than they need to sometimes, so the goal is to be back to, riding your bike or playing golf or, doing all these things within a week. They just want to be normal. And there are patients that do that, and the surgery is incredible. It can allow for really quick progress, but it's kind of finding that balance. Step one is you got to take some time to just kind of teach yourself how to move normally again. Patients have been so dysfunctional or limping or all these things that if you just kind of blow right through the idea of, I'm going to sort of reset my gait mechanics and reset my muscle strength, you might not get quite as far into get as good of a recovery as you could if you just kind of, you took that time to work through it.
Sure. It's funny.
So
No,
I'm sorry, go ahead.
Say we just did a video on this yesterday that people progress too rapidly. So
yeah, and I think that probably affects knees a little more than hips, but you do see it in hip replacements as well.
Yep. Do you consider any of your patients too heavy to have the surgery?
So I guess the answer to that is yes. I mean, the way we look at weight is very dependent on multiple factors. So sure. There's no official weight limit on a hip replacement. So it's not that you would be too heavy for the hip replacement to hold you or to function right. But a big part about being a good surgeon is making sure patients understand what their risks are and how to safely get people through surgery. And weight or BMI, your body mass index, are two big indicators to potential risks, which can be everything from those dislocations we talked about to infections, to as simple as anesthetic complications, because typically overweight patients have sleep apnea or have some more significant medical issues, or they're diabetic, and all those things can lead to complications. So there's no formal rule. A lot of surgeons and a lot of research has kind of shown that a BMI greater than 45, which is a pretty significant amount of obesity, does set you up to a very significant increased risk of a complication. And so there are surgeons and hospitals and practices that tend to use that limit as kind of their main official kind of cutoff, if you want to call it that. But the way I look at it is that weight is a gradient, and no matter where you are on that scale, that doesn't mean you're doomed to fail or doomed to or guaranteed to be successful if you're very well, if you're in good shape. It's really just kind of that risk stratifying of what does that mean? What are your other issues that go with that? And, making a good decision on, do we think this is something we can do safely and get you through it without a complication?
Right. Makes sense. So some of the patients were wondering, is it normal to have swollen legs after a total hip replacement?
I'd say yes. So, there's a few things that happen. You obviously, when you go through a hip replacement, even though it's a quick procedure, it works well, you move quickly on it, there's quite a bit of trauma that happens to your hip.
Sure.
And part of that process is swelling. So your tissues get inflamed and swell, so your muscles get swollen. You do get fluid that collects. You even get some bleeding around the hips. You can get bruising. And that, number one, leads to some swelling in general, but also it can lead to kind of giving what we call venous congestion. So your veins that are trying to get the fluid from your feet and your ankles out to your core body again, it has to go through that hip replacement area. And a lot of those veins aren't moving as well. The swelling compresses on some of that. And so that definitely leads to, like I said, sometimes swelling even, right down to your toes.
Yeah. When is it a concern?
I think if it's painful, so if it's significantly painful swelling, we worry about things like blood clots and those sort of issues. So it's worth evaluating that. And if it's swelling that doesn't really go away, so a big part of this recovery process is taking breaks, elevating your leg, icing. And if you see your swelling kind of going slowly up and down throughout the day, that's pretty common. But if you have, really significant, severe swelling that just won't go anywhere and you can't do anything about it, then definitely it's worth, stubborn swelling, is worth taking a look at.
All right, another issue that was brought up. What if you're still having pain in your hip over a year after surgery? Why might it still hurt?
Yeah. Um, there could be many reasons, and those aren't always easy to figure out. But I would say probably one of the most common reasons for continued pain is some continued muscle dysfunction or stiffness. Rehab
Gotcha.
is a big part of recovery, but there's again kind of that wide range of how far people get through that process. And I think most people that get hip replacements have had such severe dysfunction in their hip for such a long time that
Sure.
it can take sometimes a year or two or even longer to really reset all those issues.
Gotcha.
Getting your range of motion better, building all the strength up in the stabilizing hip muscles, getting your core and your pelvic muscles built back up.
Gotcha.
It's not a quick fix for some of those issues, even if the hip replacement recovers well. So I think that's probably most common. There are many other reasons. So if you are having pain at that stage, same thing. It is very worth getting reevaluated by your surgeon, because we can see kind of what we call low grade infections that could cause some chronic pain in hips. We can see implant problems, where the bone didn't heal to the implant as it should have. There are other things that could be a bigger deal or could require further treatment as well. So it's kind of a long list of things, but generally the idea is, if you're still at pain at a year,
It needs to be
your
assessed.
surgeon should
Sure.
surgeon should know about it. Exactly.
Yep. So, just real quickly, when is it okay to shower? When is it okay to drive after hip replacement?
Yeah.
So,
The
of people
showering piece of it, the showering piece of it is a little bit dependent. So most of us now use waterproof dressings, and so that
Oh,
actually
right.
allows for immediate showering. And that is really nice, obviously, because it just gives you that feeling of kind of getting back to life, being able to kind of freshen up, etc. But yeah, so right from the start you can shower. Depending on if the surgeon does not use a waterproof dressing, there are other ways to seal that off. People use saran wrap or press and seal, or there's different ways to kind of keep that incision dry while you shower. But usually
Gotcha.
most surgeons would allow it within the first couple of days.
Wow. Nice.
Yeah,
And
and then as of driving,
driving.
there's a couple factors. Which hip is it? Right versus left. If it's left and it's not your driving leg, then really the only hold on you driving is safely getting in and out of the car, so feeling
Sure.
comfortable doing that, and then not making sure you're not taking any narcotic medicine.
Sure. Makes
For
sense.
the right hip, it's a little different. There's no formal rule on it. There are some older research studies that say it does take, anytime you have a major leg surgery, it takes about 6 weeks to fully recuperate reaction time. So if you're driving, to be able to, quickly and actively operate the brake and that sort of thing. I think that I base it a little bit more on function. So we see patients at 2 to 3 weeks after surgery. And I see most of my hip replacement patients at that point are moving well enough and have good muscle control in their leg that I think it's relatively safe. So somewhere in that 3 to 6 week range is probably the average.
Well, I know there's a lot of factors to consider also for this, but on average, how quickly are people able to go back to work?
Yeah, that is a good question. There are factors. I would say I see everything for people that are desk type workers, or these days a lot of people working from home. They're going back to work within a week or so sometimes.
Sure. Wow.
It takes people that are doing more mobile work on their feet quite a bit, that
Right.
sort of thing. I think
Right.
probably the average is closer to 6 weeks. And then if you're going back to very labor intensive work, got a lot of factory workers, construction, contractors, those sort of things. It's probably closer to 2 to 3 months to really, be safe if you're climbing ladders, if you're doing heavy lifting, you know, those sort of things.
Can a person run with a total hip replacement?
Technically, yes. So I get that question a lot.
You do.
The replacement can tolerate running. You're not going to break it or damage it. You know, there's kind of two thoughts. So I guess if you're saying, you know, could I run down the street if I was trying to, you know, catch my kid, or if I'm playing with my grandkids in the yard, can I jog around? The answer is absolutely you can.
Yep.
The theoretical downside of it, which again, we don't really know the answer to this because we don't have that many people that do significant amounts of running on these.
Right.
You know, the idea is that repetitive pounding and high impact exercise would potentially wear the implants out more quickly. Now we're talking about 30+ year implants. And so, you know, the question on how much does that matter, we don't know.
Right.
But I definitely have some patients that do some light jogging. You may have a surgeon that tells you absolutely no way. And that's probably related to that mindset of, you know, we want this thing to last as long as possible. And that, you know, but I guess I go with the idea of if you have something else you can do, you know, lower impact, cycling, swimming, elliptical machines, those sort of things, and you enjoy that, then that probably makes a little more sense to be your, you know, your main mode of exercise.
Dr. Dane Hansen, Hansen.
You got it.
With Summit Orthopedics. He's in, I don't know how to pronounce this, Vagnus Heights?
It's, Vadnais Heights.
Vadnais Heights and Woodbury. Yep. And it's summitortho.com if you want to find the website. He's got, again, 55 great testimonials, so you can check them out. So thank you again for joining us. I hope we can have you again some of the time, maybe. Some more of those.
This is great. I'm happy to. I think, you know, I think these are awesome situations. I think patients really, my goal always is to, you know, help educate people, and in a 15-minute visit, it's tough to get through a lot of things. So
likewise,
having this kind of info out there, I appreciate it, because I think my patients feel more comfortable. They know they have a little bit more education on what's going on, and I think it's great. So I'd be happy to come back.
Well, thanks for taking the time.
Yes, you're welcome.
Yeah.
Thanks so much.